Good afternoon, everyone, and welcome to this qiCommunity webinar, the 10th of August 2017. My name's Tony Linkley. I'm a GP in Austenville in northern New South Wales and Chair of Faculty at the Improvement Foundation. And it's a beautiful sunny day here, as it is every day in Tipper. I'm joined today with special guest Gary Egger, who's from the School of Health Sciences at Southern Cross University and is President of the Australasian Society of Lifestyle Medicine. Good afternoon, Gary.
Morning, Tony, or good afternoon, Tony, sorry. Actually, Vice President of the Australasian Society of Lifestyle Medicine, and I'm an adjunct at the School of Health Sciences at Southern Cross. I'm actually in Sydney, based in Sydney.
Oh, yeah, and you're in Sydney today. What's the weather like down there?
Oh, it's beautiful, beautiful, 24 degrees.
We're all running out of water up here.
Just to rub it into those people listening from Melbourne.
Gary, you're well known to our collaborative practices, having been a keynote speaker at many of the functions that we've had, and you've spoken to us about lifestyle medicine. Can you tell us, what do you mean by lifestyle medicine?
Well, the definition that we have here, and we do have a textbook now that's in its 3rd edition, the definition, the working definition is a form of health promotion and branch of medicine targeting prevention and management of lifestyle-related diseases. Now, that doesn't tell you that much, except to say that this is not, it's not an alternative to conventional medicine. It's not even an adjunct in a sense. It's more a focus that you would get in conventional medicine to appropriate the area of lifestyle and environmentally related problems. And don't forget that environmentally related, because if you're just focusing on lifestyle, you're actually victim blaming. It's the environment that leads people to alter their lifestyle in an adverse way in terms of their health.
So I'll let participants know, if you have questions during the webinar, if you type them into the chat panel, as Belinda and Melissa and Hody have done. Gary, the lifestyle medicine in practice, how does that work? You say there are 4 components that we need to be aware of.
Yeah, we were actually one of the world's pioneers in this area in Australia. There's now a global lifestyle medicine association, and they're popping up all over the world. But people are now starting to look at the pedagogy and the structure of what it would be, and if there is going to be something called a lifestyle medicine, just like there would be for travel medicine or sexual medicine or any other type of medicine, what would it consist of? And we've brought it down to 4 things: the knowledge or the science, that's the epidemiology basically, and we've listed in several publications, including the textbook, about 15 different potential determinants of lifestyle related disease. Now, most people, when they talk about lifestyle, they talk about diet, exercise, and maybe stress, and maybe smoking. But there's a lot more things than that. There's the social interactions. There's the macro, the macro and the micro environment. There's occupation. There's a range of different things. We won't go into those today. There's then the skills or the art, and this adds to the conventional skills that any decent clinician will use anyway. The tools and the aids are probably a little bit different in the sense that we've got a whole stack of new technology coming up now, including wearable technology that we can use to assist patients to help alter and change their lifestyle. And then finally, which is the one that we want to talk about today, is the procedures or the actions. And I'm going to talk today about one action or procedure which hasn't typically been used in conventional medicine, but which is very appropriate for lifestyle medicine because it involves longer time with the doctor and also peer support from other people in the group, and that's the shared medical appointments. Let me first, though, before I do that, just quickly look at the other types of procedures that are available, the current procedures. The ones in white there are your typical procedures that are used in conventional medicine, referrals and prescription, brief assessments and interventions and care plans and so on. And then there's some innovative procedures coming up, many of which many people will be familiar with, such as self-management training, telephone triaging as a way of using the telephone before somebody gets into the surgery so that you can triage somebody so that the doctor's getting to see the cases that the doctor really should get to see, and some of the other allied professionals are seeing them before that. Deprescription, we actually run EduVentures up on the mid-north coast, where we take doctors and allied health professionals away for trips, 3 or 4 days, walking down the coast or out in the central Australian desert, and that involves learning procedures and a CPD course as well. But then the last one that I want to get to, the last two, the shared medical appointments and the program shared medical appointments, are a new approach to dealing with chronic diseases.
So bibliotherapy, Gary, that's giving someone something to read. Is that what bibliotherapy is?
Basically, books.
Yeah.
Yeah.
I haven't been on an EduVenture. I'll have to come on an EduVenture with you.
You should do. You should do. We have great fun. We also have patients come sometimes too, so that there's discussions go on between doctors and patients. And in fact, we have a textbook which we're just waiting to get printed, which is a walk from the Queensland border down to Sydney over 27 days. You don't do it all in one lot, but you can do it in 1 or 2 or 3 day lots as well.
Wow. All right. So Gary, the shared medical appointments, what is that? What is the shared medical appointments? What do you mean by that?
Okay, well, typically in a clinical interaction, it's in a one-to-one situation. And if you look at the evidence for this, there's no evidence that it's any better than any other type of interaction with a clinician. But it has worked in the past, because with infectious diseases and injuries and so on, it's much easier for a doctor and any other clinician, it's not just doctors, to deal with, to work with a patient in a one-to-one situation. Whereas with chronic diseases, it takes longer than the allowed time, and the MBS wasn't really set up to deal with chronic diseases when it was laid out in the 1970s. So a shared medical appointment is really a consecutive individual medical visit carried out in supportive group setting of similar patients, where all can listen, interact and learn. And this comes from Ed Nofsinger. This was the American version that was developed in the early 2000s. We've actually, use the definition here that it's a comprehensive medical visit run in groups of participating patients. So you've got 10 to 12 patients, each of whom is seeing the doctor on at an individual level, but the group is controlled by a facilitator, a trained facilitator, who's generally a practice nurse or an allied health professional, so that everybody gets a turn with the doctor, but all the other people in the group get a chance to participate in that clinical interaction. Now, the facilitator needs to control the group so that people aren't talking over the top of each other and offering, silly suggestions about different things that they've read in various journals that may not have any evidence base to them. But by doing it this way, the patient is not only getting a clinical interaction, a medical treatment by the doctor, but that group is also getting peer support, and the doctor is getting support from the facilitator in answering a lot of the questions that the people in the group might have.
So Gary, it's not that we're familiar with group education sessions on particular topics. It's not just a group education. When you're talking about shared medical appointments, there's a specific differences that you're referring to.
Yeah, and this is very hard to get a hold of until you've done one of these. But at the one end, as you can see here, we've got the clinical care model, which is a one-on-one model with the one doctor and the one patient. At the other end, we've got group education. Now, this was brought into the Enhanced Primary Care Program in 1999 so that you get support, for example, for a diabetes educator to run a group education session. But the disadvantage with that is that there's no clinical interaction, there's no medical care at that level of group education. The problem with the clinical care, the one-to-one situation, is that there's no extended education, because in many cases it's just a 6-minute or maybe even up to a 20-minute consultation, but chronic disease requires a lifetime of care. So the shared medical appointment is somewhere in the middle, where you've got one doctor, one facilitator, and probably 6 to 12 patients. The Americans do it with even 15 to up to 20, but we just don't think that, we think that's too much. And if you look at the way advertising and group dynamics people work, they normally work with a group from between about 8 to 12 people. That's where it tends to work best.
So you described it as with a doctor and a facilitator and 6 to 12 patients. So doctors participate in the shared medical appointments, and there's a question: do they get a chance to deal with individual patient problems? It's not just a general discussion then, it gets down to individual issues that patients might raise.
Yes, exactly. Each patient is asked, what are they there to see the doctor for? And this is written on a board before the doctor comes in. So the facilitator will spend 20 minutes to half an hour setting up the group, getting the questions that the patients want to ask the doctor. Then the facilitator brings the doctor in and starts off with a person. It doesn't necessarily go in the order that they're sitting, but the facilitator with their skills will pick out the right person to ask the first question of. So it's not going to be somebody that will talk for half an hour or an hour, and it's not going to be somebody who's not going to talk at all. It's got to be somebody that the doctor can bring out in that consultation. Now, the consultation doesn't get personal to the extent that there's anything that goes on that's confidential. If the patient requires a confidential consultation, then that needs to be set up with the doctor at some later time on a one-to-one basis. But in the group, most people actually, after they start to feel comfortable, they don't mind disclosing a lot of information that they thought they wouldn't have disclosed in the first place, because the other patients in the group have got the same problem as them. These are generally homogeneous groups that have all got similar sorts of problems, and we'll talk a little bit about that in a moment when we talk specifically about the types of programs that you can run in this situation.
And Gary, so I think the facilitator then is a particular role that's important for smooth shared medical appointments. Can you tell us a bit more about the team that you use and the role of that facilitator?
The facilitator is somebody who we actually, through the Australasian Society of Lifestyle Medicine, we offer a one-day training program for facilitators, which gives them a certification to do this as well. And that facilitator is normally the practice nurse, but we do have diabetes educators and exercise physiologists and dietitians that do it as well. Now in the US, because of their different funding model, they can use up to 4 people, such as here we've got the doctor, the facilitator, the practice nurse, and then you've got a documenter that records the medical records into the computer while the consultation's going on. One of the things, as any doctors listening will know, that the patients don't like is doctors typing into the computer while they're doing the consultation, and the doctor generally doesn't like that either. So we get the facilitator to do that, and there only needs to be a couple of sentences goes in for every person, so that using Medical Director or one of the other medical computer programs, you've got all those patients' records set up, and the facilitator can just type that in as well as running the group as it goes on. So in Australia, because of the funding model, we just normally focus around the doctor and the facilitator. So it's normally a 2-person program, and it operates in a room. I think we've got the photograph here of one of these operating. Yes, here it is. This was one group that we ran out in country New South Wales. Now, one of the things that people always say is, oh, you couldn't do this in a country town because everybody will talk about it. They'll go away and talk about other patients. And we've found that it's just as easy to do and just as confidential for the room. They actually sign a confidentiality agreement before they come in. But we've had no problems, and the Americans have had no problems with over 500,000 patients in terms of confidentiality. And as you know, America is much more litigious than us. So if there was going to be a problem, it would have happened already there. So you can see here we've got the doctor, the facilitator together, and there's also a documenter in this case documenting, but normally we'd have the facilitator doing it. This is a mixed group of males and females, Indigenous and non-Indigenous. It was a diabetes group, and you would think that that group would have problems disclosing in front of the rest of the group. There was no problem at all. There was no problem about them talking outside the group. We've never had problems with that with what we've done so far. It just works like a medical consultation, but also like a group education program. It's a revelation when you've done it, basically.
So, Gary, could I just say the guy now, our friend here in the blue shirt, the doctor might say now, Pete, your HbA1c came back this month at 8.6. That's a bit worse than it was. What do you think's going on? And so it's not just general education about diet. You're dealing with specific problems that individuals raise, and the other people will listen and learn because their HbA1cs might also be up or down. And so it's as if you're talking to Pete there on his own, with others listening in, and then you talk to Fred, and then you talk to, is that
Yeah,
the picture we're getting?
exactly. But while you're talking to Pete, Fred can butt in and say, look, my HbA1c was up last time, but I actually got it down. And the way I got it down was going out and I lifted some weights, or I went to the gym, or I changed my diet somehow. And then that can open a bit of a general discussion in the group, which the facilitator has got to control, because remember, the doctor is dealing with Pete in the first instance. And until he finishes with Pete, until Pete then agrees that he's got what he wants to get out of this group, then we don't move on to the next person. And by the time we've moved on to the next person, that person may not have as much to disclose, or may not have as much to talk to the doctor about, so that the 6 or 8 or even 10 minutes that Pete took with the doctor might only take 2 minutes by the time we get round to Fred at the end, or even halfway through.
Oh, I see. So it's rather than a group education session, it's a series of, which is what your definition was, and now I understand it better, a series of individual consultations with other people listening in at the time and benefiting from that shared experience.
And contributing. And that's the big benefit, is the peer support. As we know, people learn best through, or one of the best ways to learn through is through peer support. And they get the peer support by being in there with people, similar people who've got similar problems and have experienced this. And quite often you get, and we'll see in a moment, you do get groups where the patients will know more than the clinicians, and the patients can actually help, provided we know that that information is evidence-based, you know, that this is not just nonsense stuff that's coming up.
And this particular group, which is in Burke, they may or may not meet again in, you know, for their 3-monthly review. It might be the same group and get that group dynamic, or they may be different groups. Is that how that works?
That's exactly right. With this group, it may happen that they just meet once. It may be these have all got care plans designed, and therefore that makes the billing situation easier too. Or it may be, in fact, the next stage that we want to go on to is looking at an extension of shared medical appointments, which is program shared medical appointments. But just before we do that, just look at a couple of the tables here that we've got from the research that we did for the RACGP some time ago to look at the potential for shared medical appointments. And these are patients' ratings on 5-point Likert scales. If you get anything over 3 in a Likert scale, as any good researcher will know, you're doing quite well. But when you ask the question, how do you rate SMAs for type 2 diabetes? This is after the patients have come along. This is 320 patients. 4.55 for that. Would you continue to come? 4.86. Do you think SMAs would reduce the number of other visits you would need with your doctor alone? 3.8. And we actually found that when you ask how many visits do you think you wouldn't then need with the doctor alone, turns out to be about two less visits per year. So it's actually quite cost effective when it gets to that too. Now I can't see, there's, oh, here we are. No, I've gone too far. I was trying to scroll down and my scroller is a little bit too sensitive. What did you enjoy most about SMAs? Having more time for asking questions is a big one. Seeing the doctor more relaxed, and the doctors all say that they are more relaxed too. We actually evaluated the patients that enjoyed this and wanted to go back and do more. It turned out to be 95% out of those, 96% actually, out of those 320. When we evaluated the providers, the doctors, it was 100%. They really enjoy it because they're relaxed, it's more fun, it's a bit different to doing the one-on-one consultation. You're not going to do that, you know, as your only method of consultation, but it's just an add-on to what you normally do. Getting support from others and hearing the experiences of others is really important. And then getting information from others, 4.97. The peer support, as I say, that's the most important part of this whole process.
And Gary, so you know, if normal individual consultation is around 15 minutes, if you're doing 8 patients, does it take 2 hours, 8 times 15, or do you, because of what you said, that you're repeating information, you can do 8 patients in a much quicker time?
Yeah, in fact, we plan it so that you're doing about 6 minutes per patient on average, so that you can have 10 patients in there for an hour. And we normally find that that's plenty. Each patient is actually appreciates it because they're getting a full hour with their doctor. but they're having questions answered that they may have forgotten to ask in the first place. You know, as you know, patients come in with a list of problems that they want to ask, a list of questions, and they always forget after the first one, whereas this enables them to do that.
And from those numbers that you've put there, it would appear that the patients value it. They see it as an hour with the doctor rather than 6 minutes with the doctor, which
Exactly.
is an advantage.
Yes, exactly. Yeah.
And as far as the recording, there's some questions about recording the information. I guess the facilitator or the documenter can record individual patient responses in their individual notes, where that's appropriate.
That's correct.
And as far as information for the patients afterwards, there's a question about, do they get a recording? How do they remember everything that comes up?
Okay, they can. The doctor has to vet whatever is written into by the documenter into the patient's notes. Now that requires a little bit of time at the end of the session by the doctor, but that can be done outside the session. In terms of the other things, requirements for the patient, prescription, for example, they can be printed out and given to the patient at the end of the session. So a bit of time is taken there to provide ongoing material, and even to make further appointments for the patient.
And there is a capacity for limited, perhaps, Gary, if someone has a problem on their foot, you could look at their foot, or if they needed to listen to their chest, would you take them behind a screen? Is there opportunity for examination?
Yeah, there is, and some examination can be done in the rest of the group, and the foot examination is the obvious one. A doctor can get up and go over, and patients actually quite like watching that with another patient. They can learn from that as well. If it's anything intimate, of course, you have to go out into a spare room, and that time is then taken up by the facilitator, who continues the group working and talking together until that comes back. But generally, we find we don't do those side room consultations. If it's something intimate, we generally line the patient, or get the patient to line up another appointment with the doctor on a one-to-one basis at some later time.
And what do the docs think, Gary, about, you mentioned it a bit, but what's the general impression from the docs?
I've left that comment up there, an evaluation. I hope people have read it by now, but it's very honest. He says here, while you always do your best, it doesn't matter that much if I get my facts wrong or advice slightly off, as I won't see them again for ages. They have no one to check with anyway. In the SMA situation, you can't do that. Someone in your patient group or team are going to know more than you about some things. You can't fudge it. After the second SMA treatment that he did, this one, I read deeply about diabetes and am continuing to do so in preparation. So everybody learns. It's not just the patients, it's the providers that learn this process, and you learn the questions that are going to be asked in the process as well.
And I can imagine as you get more sophisticated, Gary, a documenter could keep track of the issues that are raised, discussed and solved, and that could be made available to the whole group after the session.
That's right, and they'll keep coming up. If it's a group in diabetes and you do another group in diabetes, you'll get the same sort of questions coming up all the time.
That leads us straight on to the concept that you've developed, which is about programmed shared medical appointments.
Yeah, so this is a sequence of shared medical appointments in a semi-structured form, providing discrete educational input relating to a specific topic. So basically what we're doing here is running an educational program over, let's say, 6 sessions over 6 months in a particular topic. Now, the doctor might not come in on every one of those sessions, but may come in every second session or the third session or whatever. And the program then provides discrete information as well as that individual consultation to the patients. And there's a number of different programs that we can do. This is a good one here, and this is one that we're experimenting with down the south coast of New South Wales at the moment. If you look at obesity, for example, in primary care, the evidence suggests that obesity treatment delivered in primary care has limited effectiveness. But given the influence and reach of primary care providers, we can't afford for them to be sidelined in the treatment of obesity in larger populations. So what we've done here is taken a weight loss program over 6 to 8 sessions. The last 2 sessions they get as they can come back and do it as a group, or they can do online. The first 6 sessions are done as a group. Now the doctor can be in each of those sessions or every second one or every third one. Depends on the facilitator and the doctor as to what they decide and the needs for that. And if you look at the cost effectiveness of this, as I've got up on the screen there, in that review that I just showed, you need 11 to 26 individual visits over a year to get a 4 to 7 kilogram weight loss that's greater than controls. Now, if you're billing under MBS items 23, and I can't say that you can, and I can't say that you can't do that at this stage, an average of 18 visits of 15 minutes, this would cost you $680. This would cost, sorry, $680 per patient and require 4.5 hours per patient. But if you can achieve the same results, which we suspect that you can not only do, but do better in the group situation, you're only using 8 programs or shared medical appointments with 10 patients in a group, then using the same billing system, that it would only cost $300 per patient, but it would save the GP 37 hours of his or her time, and the patient would have twice as long with the doctor, plus they'd have peer support of other people, other patients in the room. So it's very cost effective, this whole process. It's just a question of what you do it for and the sorts of programs that you might use it for. And here are some suggestions. I know you were going to ask me about this, Tony, but sorry.
So Gary, what are some other suggestions for topics for PSMAs?
Well, here's some good ones. We're doing weight control at the moment. One of the other ones that we're talking about, and we're actually got a meeting about tomorrow, is chronic pain. We've actually run SMAs in chronic pain, and now we've extended that into the program shared medical appointments, because a lot of people with chronic pain, even though the pain is quite different for many people, they still like hearing about everybody else's pain and realizing that they're not the only person that's suffering from chronic pain. We've got mothers with disturbed babies. We've got Dr. Pam Douglas up in Brisbane has been doing this for quite a while now, and she has 6 mothers and babies come in at the one time as a shared medical appointment with the facilitator and the doctor to do that. We've got diabetes and metabolic disorders, heart disease and kidney disease, and I think the low level psychiatric or psychological problems, anxiety and depression, for example, this is a great platform for dealing with that. I think when you get to the extreme ends of depression, they certainly just need one-on-one and probably even psychiatric attention at that stage. But at the early stages, particularly with men, because men don't realize that other men also suffer depression, and they get quite a surprise when they find that out.
So Gary, thank you for that. Now there's an elephant in the room that we glossed over a bit, which is about the Medicare aspect of it. You said it's a little bit unclear whether these consultations qualify for an MBS. You can't get an answer on that. Is that the state of play? I gather you've spoken to the federal government about the opportunities that SMAs offer. What sort of feedback have you had?
We've actually been speaking to them for 4 years now about it, and we have several written communications with them, which generally say we can't say that you can, but we can't say that you can't charge an item 23. When we first went to Canberra, they said, well, they said it's got to be one doctor with one patient on one occasion, and we said, well, it is. There's just 10 other people there listening and contributing, and they said, well, we hadn't thought about this when we set up the MBS, or nobody thought about it when they set up the MBS system in 1970. So we'll have to think about it. Now, as events have transpired, the medical homes model that's being looked at the moment and being trialled in those 10 PHNs around the country, that negates any concern about using MBS item numbers, because you're getting bulk paid in advance for dealing with these patients at different levels. And if you can keep your patients away from coming back for an individual consultation, then it's to the advantage of the surgery to do that for that payment. So anything that's going to work to make people better and not have to come into the surgery is going to be beneficial long-term financially for the centre.
Okay, well that's fantastic, and that's an excellent overview. I feel I have a much greater understanding of shared medical appointments and program shared medical appointments, and I'm sure our participants do too, Gary. We've addressed most of the topics that have been raised. I understand that the MBS task force review may not be dealing with this because they're mainly dealing with getting rid of item numbers rather than adding new ones. Yeah. But we shall continue to talk to our politicians and the department about the benefits. And as you say, it's been valued both by the patients and by the doctors who participate in the program. Gary, thank you very much. Is there anything else you wanted to add?
For people who are interested in taking this further, they can look at the Lifestyle Medicine website, which is just lifestylemedicine.org, lifestyle medicine, all one word, .org.au, and there's a whole section in there on shared medical appointments.
Excellent. Well, thank you very much, Gary, for that very clear presentation. Those who want to follow up, lifestylemedicine.org.au, or they can contact the Improvement Foundation, who can contact Gary on their behalf. Our next meeting coming up in September on a date that may be September the 12th, but it might yet change. And that's with international guest speaker Marjorie Godfrey, who's an expert on microsystems and person-centered care, and we look forward to that one. So once again, thank you, Gary. Thanks to Alison for organising that in QI Community Central, and thank you for all our participants. And we will see you in September. Thank you.